Hey everybody, I'm your four-eyed professor, Chris Levens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session. Hey everybody, thanks again for joining the Four-Eyed Professor podcast. On this episode, please understand that the opinions presented by myself and my guests do not necessarily reflect the opinions of Heidelberg Engineering. Please enjoy. Hey everybody, thanks for coming back to the podcast. We are again tackling some of the intricacies of Heidelberg Engineering and their technology, specifically talking about the Glaucoma Module Premium Edition and really what it offers our patients. I'm delighted to have two expert colleagues with us on the podcast today, Dr. Swaroop Swaminathan and Dr. Jim Williamson. So I'm going to bring them in and add them to the stage so they can tell a bit about themselves. Thanks for joining us and taking some time out of your busy days, guys, especially on this weekday. But I really think that this is critical information. I really think the audience is going to take home quite a bit from it. So thanks.
Thank you, Chris.
Thanks, Chris.
So Swaroop, please tell us a bit about yourself and your background and what are you doing pretty much on a daily basis now?
Yeah, sure. Well, thanks for having me and looking forward to a great discussion. So I am an assistant professor of ophthalmology here at Bascom Palmer Eye Institute here at the University of Miami. And I've had the fortune of working here for the last 4 years. I did some of my training here. I was a resident here, did my fellowship training at Duke with some great mentors there. And then I returned back here to join the faculty now 4 years ago. Can't believe that. And, sure does. And it's been great being back. My practice is, primarily glaucoma patients, of course, some cataract patients as well. And I also am fairly involved with research. I do a lot of clinical informatics work, EHR work, statistical modeling for progression in terms of our patients in the glaucoma world. So it's a nice mix of different things. And love using the spectralis and looking forward to discussing it.
Fantastic. All right, Jim, how about yourself?
Yeah, I'm here in Memphis, Tennessee. Elvis is still alive, in case anybody was wondering. I've been here for, 22 years, the residency supervisor at the Memphis VA Medical Center. And like Swarup said, I've been with Heidelberg since, we've been with them for years with their technology. So as well, I'm looking forward to discussing what they have to offer us.
Fantastic. All right. So besides the topic of patient compliance, because that's way too in depth and we'd be talking for hours at how to get human beings to follow our instructions. So besides that piece of it, what would you say, and either one of you or both of you, are today's challenges in 2023 in identifying glaucoma, monitoring glaucoma, or managing glaucoma?
Jim, you want to go ahead?
Sure.
I want to ruminate on it.
The identifying glaucoma sort of rang with me because I think that's the thing I see the most with, training residents and students. And also in some of the patients that come through our clinic that have been diagnosed on the outside with glaucoma, there's just so many intricacies that are there that can fool you into thinking that either you do have glaucoma or, that it's something else going on. And, as we'll talk about, I'm sure here in a little bit, there's some good things about the GMPE that I see that can really help tease those things out. We can sort of differentiate those things. So I think that's an important part of it all. Compliance is always going to be an issue. I'm not on the surgical side, but I would really be interested in, hearing any discussion on, the surgical MIGS procedures and getting away from eye drops to something that's more quote unquote permanent, I guess, for our patients to sort of offer them a different alternative because it's hard. It's very difficult.
Mm-hmm. Yeah, great points, Jim. Yeah, I think, Jim brings up some great points. I think, there's a lot of things I think trying to, share with trainees, for example, the fact that, when we're thinking about glaucoma, it is a progressive process, right? So, you can't tell you the number of times, we get sent patients, especially since we're kind of a tertiary care center and, people refer in patients, they get sent to us for glaucoma. But turns out they just have a massive scar along their superior arcade and they have an inferior, visual field defect. And yes, there's abnormalities in their RNFL, but is this really glaucoma? I don't think so, right? This is a chronic most likely static, no longer kind of, it's not a dynamic process. And so, this patient's been on drops for years. I mean, I had one patient who she had been on drops, I think, for 15 years. She had been on like 3 drops, and I took her off of everything. And she was like, she was willing to give me like anything. She was so enthralled by the fact that her eyes felt great, her pressures were fine. This was so, understanding and, appreciating what an anatomic, variant might look like, or a non-progressive kind of, anomaly in somebody's retina, and how that can affect, an OCT scan or a visual field is really important. And I think that can be, important to tease out. One of the things I really like doing with patients in terms of, helping them understand, their disease is actually pulling up that scan,
Hmm.
on the spectralis, and showing it to them, saying, here, look, here's something, here's the area that I'm worried about, and here's how it's changed. You see how it's gone down. And that kind of, I think, helps them, appreciate, hey, I need to take my, maybe take my adherence a little bit more seriously. And I found that to be helpful in terms of patient education.
So let's piggyback on that, Swaroop. So, for well, as long as I've been practicing, we've always had the ability to look at the optic nerve, so visual inspection. And for years, before I began practicing, we've had some auditometry. But since I've been practicing, has been the advent and emergence of additional imaging, like we're talking about today. So you mentioned an opportunity to show the patient, what is laid out fairly reasonable, not as complex visually as a visual field. And most patients have no idea what the inside of their eyes look like. So that's an advantage. Are there any other advantages with regards to imaging in helping us to manage glaucoma, or alternate thinking when it comes to identifying either early case or identifying subtle progression?
Yes, I mean, I think that I really like, pulling up the B scans. To me, I think that's super useful for our patients. And again, kind of, the feature in the spectralis, where you can kind of look through, let's say a circle scan, and, look at the priors, compare it to today, and you can kind of march through, right? And you can show a patient that, this has changed. Or even in the macula, I love, I think this is a crucial aspect of the GMPE, is really getting that 61 line scan in addition to your optic nerve head scan. I mean, there's just so much information that you get from that scan. It helps you monitor potentially other pathology that the patient may have. Maybe they have some dry AMD, which people have been following, and then you look and, hey, we've got some fluid. This patient's converted to wet. We need to get them to retina. So there's just so many advantages to, I think, getting that scan. And in the same way with that 61 line scan, I think if I notice an area of loss, I particularly, you asked about, subtle progression. I think I really like using the posterior pole report, or I guess the view on the spectralis, to kind of compare my macula scan from prior to today, and really look for that arcuate like change. And again, that can be really powerful to share with the patient. Hey, I'm looking at this area, see how it kind of looks like an arc. That means that there's some change there. And again, I can beautifully use that 61 line scan, go to that area where there's loss, and kind of toggle between scans and show them that. Again, you're not doing this to every patient, right? But I
Sure.
think in the patient where you're really worried about them, they're young, aggressive disease, strong family history, thin packies, people who you're really worried are going to develop visual disability. I think and I mean, touching on a point, I'm going back here for a second, touching on a question you started with before. I think that is an essential thing to share with trainees and with everybody. We're getting so good with technology that we're picking up, early changes, right? Really early changes,
Right.
which is great. And sometimes it can freak patients out. So I try to tell them, like, hey, our technology is really good now. 20 years ago, probably wouldn't have picked up on this. But I think it's just important to keep in mind and remember that, you know, not everybody is going to potentially develop visual disability, right?
Right.
There is that subset of fast progressors and folks with really, really high risk, and that high risk group. And that's what we're trying to really make sure we identify. And so as we're going through our clinics, I've tried to share with the fellows and residents at our institution, as you refine your clinical practice, it's about also understanding with which patients do you need to spend a little more time. and really try to hone in on, sharing what their test results are and why they need to be worried about their disease and take it seriously. So just touching back on another point, Jim, go ahead and
I like it.
share your thoughts as well.
I concur with this, especially with the macular scan. People will talk about, well, it's so hard to segment the ganglion cell layer, and but it actually does a really good job of doing so, and so it gives you great information about that. You can, like Swarp said, you can toggle back and forth between the two. Also the multimodal imaging. You talk about imaging, being able to do your blue autofluorescence and being able to show some of those RNFL defects that you see. I think those are powerful to show patients. You can show a nice healthy control with their fiber layer looking really good versus them that has maybe a defect in that macular vulnerability zone or wherever, and you can see where the loss of axons are. So I think that's also an important part.
So there's an intriguing attribute of the GMPE that they call the APS, the anatomic positioning system. Whereas if you took a perfectly designed eye and the optic nerve is oriented beautifully like a clock and directly temporal is the macula, then we can easily collect data and analyze data from hemifield, for example, to hemifield. However, we're not all built beautifully. And so there can be a torsional change of the optic nerve insertion from 1 degree, 2 degrees, 3 degrees, 4 degrees, where if we don't account for that torsional change, we could actually be comparing retinal layer segmentations apples to oranges, or a posterior pole asymmetry analysis in which the data is symmetric by the way it's being analyzed. So I think that that's a nice attribute that is done automatically without any user interface to deliver quality information that's consistent. Do you see what I'm seeing with regards to that advantage?
Yeah,
Jim, go ahead.
yeah, no, thanks. We saw it earlier on, when you get those sort of symmetrical RNFL shifts where the scan looked the same, but the whole shifting was, say, to the right or to the left or whatever. And I think that's great. Off topic just a little bit, but Andrew Lee would be happy with me right now talking about the Parks 5-step. And you could pick up your skew deviations and your fourth nerve palsies using this too, because you can see the rotation. That's kind of nice to have. But no, I think it gives you an accurate scan. And when you compare, if you've been with spectralis long enough, and you compare that old RNFL scan to the GMPE, you don't get those same shifts with the GMPE. So it's pretty valuable.
Yeah, those are great points. Two things that come to mind. One is I was reviewing a scan for a patient before they walked in the room, before I met them. And I saw one eye had a deviation of about 15 degrees, right?
Whoa.
Right. So I was like, what's going on here? So then the patient, I saw that I went into the room, and talking to the patient, clearly a little bit of proptosis, chatted a little bit, has thyroid issues. I said, you got to go see
Sure.
plastics. So, I mean, again, the point, this is exactly what Jim just said. I mean, the scan can give you so much information. It's not just about glaucoma. And what was actually quite beautiful about that scan, though, is because it had adjusted for that rotation.
Mm-hmm.
Actually, the tisnet was totally fine, and the patient actually had no RNFL loss. But if that adjustment had not been made, I'm sure it would have been completely all over the place, right? So that's one thing. And the second thing I was going to mention is I think that the APS is so crucial for those follow-up exams, right? So when you get those RNFL follow-up change reports, which I really like to use when I see my patients back, it is so crucial because you really can see when a patient is stable, they're really stable. I mean, those scans look really great. I mean, of course, you may have some hyaloid traction, changing things, and you have a little ERM here and there. Those things are obviously going to happen. But in most of your patients, I mean, if they're stable, those tisnet plots look really nice and rock and stable. And so that's thanks to the APS, right? Because any sort of adjustment it's able to pick up on and account for.
So you guys have hit on a number of things that just keep rolling the questions to my head, but I have to promise the audience that we're not going to be here all night. So I'm going to do my best to recall all the things that came to me. So, the T-SNP plot, that came to us through new technology, even though prior to these imaging techniques, we always used the isn't rule. So then, with the hood report, we have the opportunity in this module to go back to a not a double hump in the traditional way that the T-SNPs plot, but now more like the isn't rule, which we used to use way prior to imaging. So I guess my question is, do you guys use the hood report, and in what ways do you use it, either for patient education or your own edification for patient management?
I would say that I personally don't really use the hood report. I think it tends to, for me, I think it's a little complicated to share with patients primarily, number one. Number two, frankly, given that I have a lot of trainees in my clinic and they're not used to seeing them, frankly, it would be a lot for me to kind of go through and kind of get them up to speed with it. I find it useful in demonstrating, I think, a few nice findings when there's a very focal loss.
Mhm.
So the one aspect of it that I like is, it overlays, the 24-2 or 10-2 kind of points with kind of the RNFL or the GCL. And I have one or two cases that are very beautiful, whereby, very focal RNFL loss. And when you look at their visual field, it's beautiful. I mean, there's a very focal scotoma right where that's. So I've used that, for example, for teaching cases to share conferences and stuff like that. But I wouldn't necessarily say day to day that I'm using it. And I think the TISNET for me, it's something that I've trained with,
Right.
and I think it's easy for me to communicate with my trainees, and I feel like it provides me the information that I kind of need. Jim, what are your
Uh,
experiences?
I completely agree. I do the same thing. I use it more so in the training set because, to let them know that, yeah, temporally we should be paying more attention to the nasally, right? And then with the hood report, it puts it right in the dead center. And the visual field thing, you just can't. That's fantastic. So you can see
Mhm.
because people don't realize how few points a 24-2 has really in your macular area. So I'm the same way,
Mhm.
but on a day-to-day basis, not so much so. But it's definitely valuable for that to be able to kind of give some further understanding of the process.
Yep. And when you back out of the GMPE, we are back to TSNT using the spectralis. My personal experience was I was fortunate enough to be moderating the Arvo session in glaucoma when much of Don Hood's PhD candidates were launching the first round of research with regards to this. And so it just blew me away being able to visually mesh the field and the image together in the retina and the nerve findings so that it really shows you firsthand form and function in a way that we really hadn't seen it before. But I do appreciate, the challenges going back and forth, and the challenges in training, especially because you're looking at two different plots that look very similar in a plot, but can be very visually confusing when you just switch the rules. So now I'm about to ask you what I think could be the hardest question, and that is the challenges that we face in both seeing patients as well as teaching with regards to relying on color coding. So we've had a lot of discussion over the years of what we refer to as red, yellow, green disease. And so historically, we had automated perimetry. The Humphrey visual field on a dot matrix printer had no choice but to print in black and white. And so we were forced to learn how to analyze data and decibels and apostomes and changes in sensitivity on a black and white print. Well, now fast forward to launch of imaging. Well, we have color printers, and so industry, in an attempt to assist us, gives us red, yellow, and green in plots across all competitors, including Heidelberg. Well, I can tell my students to, okay, ignore the red, yellow, green, but it's red, yellow, and green. It's impossible to ignore. It's facing us. So how do we still dig into the data and the numbers and not be confused by confounding presentations of color that can be inaccurate?
It's a great question. Jim, why don't you take this one first, and then I'll jump in.
Yeah, this question probably would take both of us like 20
Yeah.
minutes to answer because there's just so much to it. I mean, you think about the red disease green. I think the biggest thing that people don't understand is the database. Well, there's a couple things. I'll try to be brief. The database is just a reference database. It doesn't really mean a whole lot. I think that's probably a big thing because people try to, on one scan say, okay, you've got glaucoma or whatever. The other thing is, I think they don't understand, and Carden came out, and I think it was Chen on that article in 16, talking about some of the ways people misinterpret the OCTs. And we see a lot of the RNL shelf shifts from, hyperopes versus myopes, where the the humps are shifty, they're temporally or nasally. I think that's a big thing that puts things in red and highlights everything. I think those two things are probably the most important things I try to teach the students and residents is you're looking more to trend analysis for these people. So just because something's in the red doesn't really mean anything right away. It's something you need to watch or it might flag, but then you have to obviously take into account many other factors when it comes to evaluating the optic nerve.
Yeah, I mean those are all great points. Yeah, again, as Jim just said, the reference database is just a reference point, right? I mean, functionally, it's important to know, the characterization of the database. Thankfully, the GMPE has the updated U.S. ethnic mix, which is great, right? So that's definitely better than the prior, which was I think just primarily European descent individuals. So that's a huge plus. But there's also refractive limitations, right, in terms of the reference database. So you're minus 10 myope, like myself, it's not going to be a great scan. And so, I mean, just to Jim's point, I've scanned myself and, shocking, my infranasal sector is red. Well, that's because as a big myope, my bundles are shifted temporally, right? So, that's important to recognize, right? That we have to keep in mind that, the anatomic shifts that you can see in your patients. And the second thing I would say too, though, is I really tell, my trainees to focus on the Tisnet. I think the Tisnet has just so much information. And I think, it's easy to look at the colors, I think, as you're pointing out, as you're stating. But ultimately, it's important to look at what is the overall kind of topography of that Tisnet, right? To Jim's point, if the peaks are there, they're just shifted. That's not pathology, right? That's just an anatomic variation. But when there is the peaks themselves are off, then that's, or, kind of blunted or there's a lot, that's when you need to pay attention and kind of ask yourself, okay, is there something more going on? And then, really, confirmatory, perimetry testing, looking over those pressures, what are the other risk factors, what's the appearance of the nerve, putting that story together is really important. And, in the same vein, green disease, what do we have to remember? You can be in the green if you drop from the 80th percentile to the 10th percentile, you're still green.
Right.
You can drop from the 50th percentile to the 6th percentile, you'll still be green, right? It's only 5 to 1, between the 1st and the 5th percentile, you're going to be yellow, and then under 1 will you be red. So I try to, every time I, give a lecture to the trainees about this, remind them that, that doesn't mean that you may not be having loss. And, to Jim's point, you really have to be monitoring, right? And so looking at, okay, how was that Tisnet before? How does that Tisnet look now? Yes, that supratemporal sector is still green, but there is a change, and we have to be able to kind of be astute to catch that.
So one of the other attributes about the GMPE is its auto rescan function, and its ability to identify and then recall immediately ocular internal landmarks so that the same areas can be precisely rescanned with the whole intent and goal to look for very subtle progression that's very exact, reportedly up to a change as small as 1 micron. How important is that?
I mean, I think, it's kind of going back to our discussion before about the APS. I mean, I think all of this just helps really reduce test-retest variability, right? That's ultimately what all these things are trying to get at, to try to reduce test-retest variability, make it easier for us to detect progression by reducing that test-retest variability. For the vast majority of stable patients and kind of patients with minimal other intraocular conditions, it obviously is great. I will say, and I'm sure all of us can comment on this, patients who have diabetes, patients with uveitis, patients with, VMT or, some sort of other vitreoretinal process can be just tough, just because that's the nature of the fact that they have waxing and waning degrees of other pathology, and that can affect the scan consistency. But, in terms of our other patients who are, pretty otherwise stable in terms of their ocular disease, I find it, extremely useful and very beneficial. It's helping us with gauging progression.
Yeah. Before you jump in, Jim, That exact same thought came to me when I first launched this platform. One of the things that I questioned was, okay, I understand that we're looking at RNFL scans, for example, and there's three different circles of varying diameters outward of which these scans are being taken. I was like, well, why, do I really need that? Until I had a patient with some retinal pathology that was interfering with
Yeah.
the singular circle that's in other competitor scans. So it's one of those things where you don't know you need it till you have it in front of you and you need it to really give you a high quality. And when you have the option to deliver additional data or flexibility to manipulate the data and still be able to interpret it accurately, then I think it becomes really powerful.
Yeah, I
I
definitely
didn't mean
agree
to
with that
jump in there,
too.
Jim.
No, that's fine. No, I definitely agree with that too. I've used it. I don't use it a lot, but when I need it, like you said, it's there. So that's a good feature.
I would just to add to that, I think ultimately this is what we're talking about. The key, I think, to using any software, but especially GMP, where you can get a lot of information and it can be overwhelming,
Mhm,
right? The
mhm.
key, I think, is knowing when to look at certain things, right? Because we don't have time to go through all three circle scans and look at
Right.
the, neuroretinal rim the key is knowing when to use certain tools. So to your point, you're exactly right. If you got a patient with pretty bad peripapillary atrophy, and that's going to interfere with your 3.5, scan, go out to the 4.1, go out to the 4.7, look and see if you can, and then maybe that's where you monitor your patient. You're going to use that
Sure.
4.7 scan. The other time that I found it to be useful is, let's say there's an area on the 3.5 that I'm suspicious that there looks like there's some change on that Tisnet. I'll see on the 4.1, do I see a similar loss in that area? Let's go look at the 4.7. That seems suspicious too, right? So it's just for improving your assessment of and confidence in saying that there's change.
Yeah, one of the things that I really wasn't aware of until I specifically inquired about it was, so we've always had the Spectralis with this platform, this glaucoma module added to it. So I really did some research in what if I didn't have that? What could or I couldn't do? And as it turns out, some of these things can be done without the glaucoma module premium edition, but it requires entirely manual manipulation by the scanner. And so most practices, number one, have no idea of that. Two, they probably haven't trained their technician to be able to do that. They haven't told the technician they want that. And so to import a platform that does it all instantaneously without question just delivers the data to you so that when you want to dive in, manipulate, pick out a certain point, you have the autonomy and the ability to do that versus looking happenstance and I wish I would have. If only we had, which I think in my opinion, I really believe everybody that employs this Spectralis and has glaucoma patients or a glaucoma practice really needs this plugin. It does to rely on the practitioner or the technician to predict and dictate every single thing pre-scan.
Yeah, I agree. And it's interesting.
We lost.
I'm sorry. Can you hear me? Okay.
I can hear you.
Okay, good.
Uh,
Yeah, that's a
So,
great
can
point.
you hear Jim?
yeah, I can hear
Okay,
Jim
then I
fine.
must have lost him. That's okay. It may
Okay.
be my audio patch.
Hopefully the recording's still catching him, but can you hear me?
I got you now.
Yep.
Okay.
Okay, good. Perfect.
Got you.
What were you
I'm
saying,
sorry.
Jim?
So
Sorry.
I missed your reply.
No, I pretty much was done. I didn't have anything else really.
Yeah, no, I think that it's yeah, I think it's such a useful tool again to help you. The goal ultimately of all, I think, of all the various aspects of the GMPE is to reduce test retest variability, right? Ultimately.
Yeah.
Let's just really make it as consistent as possible to make it better and easier for us as clinicians to be able to identify change, right? So that's the ultimate goal. And I think, the APS, having those three rings, the ability to really, adjust, for that location, that fovea, all those things are just really so valuable in catching subtle change.
Do you feel Heidelberg's strategy at assessing the optic nerve head is unique? It really uses the Brooks membrane opening to tackle, where exactly the break is between the disc and the cup. Do you find that important in comparing and considering other methods for you to be able to get that same information?
For me, this has been since we got the GMP, it's been fantastic because I've been able to use some other platforms over there that you have over there at SEO, Chris.
Hmm.
And yeah, the one thing about it is it gives you a chance, even before you begin to scan, to tell the machine whether it's segmented the BMO right. So if in the beginning when you're doing your first scan, it says, confirm this, confirm that, you confirm it. And it is nice to see that Brooks membrane opening. I don't use the BMO a whole lot as far as the measurements of the
Hmm.
BMO goes, but I think that it gives you a couple of great data points. One is the nerve size. And, Sarup, being a trainee of Dr. Medeiros in the 5 Rs, well, no, you got to look at that scleral ring. So, you can always see hey, is this person, we going back to the reference database, if they're the 2.9 nerve, the size cut off at 2.6, I think. So they're not even in the database there. And if I'm seeing a larger cup on a 2.9 or 3.1 nerve, that might not be, a pathological entity there. So I think that's good. The second thing is when you're doing that radial scan through the nerve, you can look at other pathologies that are going on. I mean, uh, for me, I like to look and see what the health of the lamina cribrosa looks like. I can see what the cupping is. I'm able to detect pits. Hey, I might detect some optic nerve head drusen or those little drupelets that I would have never scanned before had I not done the GMPE. So you can get lost sometimes looking at that scan and the radial thing going around and like, oh my gosh, I'm seeing this, I'm seeing that. So I think that gives me when I'm doing the GMP. That's one of the things that I've really enjoyed about having the product. Sound like a
I think that
salesperson. Sorry about that.
I think to Jim's point, I think again it's about looking at those scans when you need them. I agree. I don't think I necessarily am using the BMO scans, super frequently, but I was nodding as Jim was sharing. I can remember a few patients where very odd optic nerve, not a ton of cupping, but some RNFL loss. And
Hmm.
I, instead of having to necessarily send that patient down for an autofluorescence or, try to get a B scan or something, we looked through the nerve and, there was some drusen, kind of buried right there and could explain kind of what we were seeing. So again, to me, it's about, when you need it, the data's there, right? Again,
Right.
you're not going to use it in every patient, but taking the extra time to get those scans just gives you the ability to reflect on it and look at the data when you need it, and that it's incredibly valuable.
Yeah. One of my favorite attributes, excuse me, is the ability that the GMP offers in allowing me to basically select anything and track progression on repeated scans. It's not just one thing that I can either track progression or not. I can customize that on any part of the nerve and any tissue and look for changes over time. Do you employ strategies like that in looking for patients who maybe are progressing in field loss, but visually, you're not seeing other things going on?
I mean, I would say I think there's definitely some possibility in terms of doing that. I think to me personally, I kind of rely, like I shared. I think I think that sometimes the segmentation can be a little bit challenging, right? Just from scan to scan, and if there's some degree of segmentation error. So I will perhaps look at kind of trending, a GCL or an IPL layer over time, but I personally tend to stick with your total retinal thickness for a couple of reasons. One is, ultimately, if the patient doesn't have any ocular pathology, that is a pretty reliable metric overall. They don't have AMD, they don't have DME, they don't have anything that's actually going to cause some aberrations, right? That's going to kind of confound your assessment of the total retinal thickness.
Right.
And if you think about the patients with AMD or DME, and I think some folks will say, okay, well, other devices will give you that GCC or GCIPL assessment, but I would counter with the fact that eyes that have any sort of pathology, I can bet you that segmentation ain't great, right? So it's not necessarily reliable in those cases either. So I personally, I tend to kind of look overall at the total retinal thickness, and then, if I'm really kind of curious about a specific, patient where something isn't adding up, maybe I'll look at the GCL or the IPL and kind of trend that. But again, I'm a little bit more careful about that because I think you're going to have more variability just from the test retest aspect of that.
And you could always,
The last,
oh, go ahead, Chris. Sorry.
no, go ahead, Jim. Go ahead and chime in.
No, it wasn't. It was just a comment. It wasn't
Okay.
overly intellectual.
Now, really, where I want to end, where I really want us to end and wrap up is just, put on your binoculars and look towards the future, and give us, your best guess of, say, 5 to 10 years from now. Where do you see glaucoma management going? Do you expect us to employ exactly what we have today? Is there going to be different? Are there going to be additional diagnostic tools? Where do you think the glaucoma manager is going to, how are we going to look different in a few years?
Well, I'll answer this because mine's going to be pretty short because I'm not into the research part of everything. But I will say this, and just in that question only, if you're managing glaucoma, don't forget to take color pictures because pictures are going to outlive any technology. I mean, if you took a picture of the nerve from 50 years ago and that person's still here, you can compare that nerve to what you're seeing today. So I think that that's an important thing to remember for all of us. A lot of Swarm talk about what he thinks technology are going to go. I mean, there's some things that are out there now that aren't in the, aren't available commercially to be able to assess, the nerve fiber layer. And if you get to the floor effect, how do you measure anything after the floor effect? And some of that new technology that's out there is looking to try to solve that issue. So it'll be interesting.
Yeah, so I think lot to unpack here. I think Jim, I think Felipe would love you for saying that because I'm sure you're he's developed a pretty nice model looking at optic nerve photos and kind of assessing what the RNFL thickness are is from that photo. But I think you make a good point. I mean, SLO, OCT, things change, but optic nerve photos from 1990, you can still take a look at it, and photos still useful. So I think it's a great point. With respect to kind of what we were, the question, it's a great one. I think there's so many moving parts. I think there's things, OCTA has been in the mix, it's kind of interesting in retina. I'm not 100% sure about how its utility will be for us in glaucoma, but that's something that, perhaps maybe in the future we may find utility there. There are things like optical texture, analysis, right? That's become an interesting thing, and kind of assessing the RNFL, that could be important. I think somebody asked this question to Don or Joel Schumann or somebody about OCT that, if you could walk it back and you went back to when OCT was developed, would you still have created the idea of a Tisnet plot? Or would you have just looked at the scans raw? And it's an interesting question, right? Because at that time, you didn't have the compute to process scans, right, at that level. And so we had to rely on kind of some of these summary metrics. Looking into the future, I mean, it is possible that, and this is why data like what the Spectralis and GMP captures can actually be incredibly powerful, because the more data that we have, I think we're going to get to a point where we're going to have compute that can actually do more analysis on it. For example, I actually really like this feature. I don't know if you guys use it at all. The 3D feature in HIX. I found it to be great to show patients who have very bad disease, where there's a very localized disease. There's a big, kind of, valley or trough. I've pulled that thing up and shown it to them, and they're like, wow, that's my eye. And you say, yeah. And so I bring that up because, clearly, Spectralis is showing you there's a lot of data there to unpack. I mean, there's 3D information, right? There's an X, Y, and Z component to that. So there's a lot there. And that's not even withstanding the possibility that we're probably going to see things that are going to, some of the work that I kind of am focused on, how do we integrate things together, right? How do we integrate, our visual field? How do we integrate our pressures? How do we integrate, patient characteristics? How do we do that in a way that's a model, not just, Jim having to do this in clinic, looking at the OCT as we do now, and then flipping over to the, EHR. Okay, here's what the pressures were. Because what we're doing, what are we doing there? We're just figuring out what is my probability that this is progression or not. And we're using all these factors to do that, right? So there are modeling techniques, that's something that I particularly am interested in, and many others are, in terms of figuring out how can we automate this in a better way, right? So I think we're going to see, a whole host of different statistical approaches. Everyone's always excited about AI. I think, we should just be cautious about it. I mean, it's something that I think there will be a role, but it is going to be a lengthy process, because obviously for anything to become FDA approved, there needs to be a significant vetting process. And as with everything, and this is, I guess, a theme of the evening, you have to use it in the right context. Right. You don't want to be a hammer looking for a nail. I think, it needs to be employed appropriately and sensitively. So I think that's going to be important as well in terms of how it's rolled out. But I think the way we care for patients in the future, I think, is going to be a little bit more integrated. Instead of us having to compile information in our brain, I think there is going to be more technology that is going to synthesize for us, is going to provide an assessment of, the probability that this patient is probably having change is this, and here's the reason why. And then we will use that to kind of guide our care for a patient. So I think that's kind of the direction we'll be seeing things in a few years.
I love it. Well, you guys have been fantastic. So I think the big take home from my perspective anyway is everybody keep doing what you're doing. Do your best to take care of your patients. Do your best to early identify and identify subtle change. And if you have a spectralis, you should be employing the GMPE. And if you aren't, really consider it, because this is offering us a wealth of knowledge and opportunity to take care of patients in a newfound way. Thank you guys for spending your personal time with us, and thank you to the audience for listening. Please tune in again to hear some more topics. Class has ended for today, and we have no exams or grades approaching. Please email me at foureyeedprofessor@gmail.com if there are topics that you would like to hear and see through a professor's eyes.